Good morning, TGIF. This video is about the chronic bone changes in the patient on hemodialysis. Yesterday, I had this elderly patient. She's in a wheelchair. Of course, she has a chronic renal disease. Has been on dialysis for several years now. She has complained that her bone hurts badly. And I wanted to talk about how the bone is affected in chronic kidney disease, and that too particularly in patient on hemodialysis, end-stage renal disease, ESRD. It's extremely common problem and clinically important. So chronic kidney disease is called, basically the term we use is mineral and bone disorder. This is just not a bone problem, it's a systemic metabolic disorder because it causes imbalance in calcium, phosphorus, vitamin D, parathyroid hormone, and vascular and soft tissue calcification. So why do bones get affected in ESRD, which is end-stage renal disease? Now, healthy kidneys activate vitamin D, excrete excess phosphorus, and helps regulate calcium levels. But in ESRD, phosphorus accumulates because kidney is not functioning. It cannot activate vitamin D as much, and calcium level drops. Parathyroid hormone level rises. It causes secondary hyperparathyroidism, and this results in abnormal bone remodeling. So, number one is secondary hyperparathyroidism, which we call osteitis fibrosa. And that's the most common disorder, bone disorder in ESRD. The way it happens is this: you have high PTH, parathyroid hormone, because of low calcium and high phosphorus. That leads to excessive bone resorption. So there's a high turnover bone disease. So patient have bone pain, fragility fracture, subperiosteal bone resorption, brown tumors. Skull looks like salt and pepper because of bone resorption. Labs will show high PTH, high phosphorus, lower normal calcium, and increased level of alkaline phosphatase because of high bone turnover. Now, second bone problem we see is called Adynamic bone disease. It's common in diabetics and elderly dialysis patient with oversuppressed PTH. That means these people have excess level of vitamin D, and so they have a low PTH and low bone turnover, and they have high fracture rate and vascular calcification. Then we see osteomalacia. Osteomalacia is because of vitamin D deficiency, and the bone becomes softer. People have bone pain, muscle weakness, and they have a pseudo fracture. The zones between bone becomes loose, called looser zones. Then you have osteoporosis, and sometimes it coexists independently of bone mineral disorder in chronic kidney disease. But dialysis patients have 2 to 4 times higher fracture risk. Extraskeletal complication. People, with the hemodialysis, they have vascular complication, calcification. They have a higher risk of cardiac mortality. Sometimes they also have a necrosis of the skin called calciphylaxis because of the vascular calcification of tiny blood vessels supplying the skin. So what we see typically in patients with the ESRD, the phosphorus is high, calcium is low or normal, PTH is usually high, parathyroid hormone, vitamin D is low, and alkaline phosphatase is high because of high bone turnover. So how we manage them, we need to control phosphorus, dietary restriction. We give them phosphorus binders called calcium acetate, Sevelamer. Sevelamer is other medication. And we try to correct vitamin D deficiency by giving calcitriol or vitamin D analogs. And we also try to control PTH by giving sinacalcet. Sinacalcet is we call it calcimimetics, sinacalcet, to control the PTH. In rare cases, the parathyroid gland has to be removed. And of course, you have to optimize dialysis. So high PTH leads to high turnover bone disease. Very low PTH also can cause suspect adynamic bone disease. So in the way to be diagnosed is a bone biopsy, but we rarely do that. Fractures risk is very high in ESRD patient and carry high mortality. So bone disease in ESRD is a metabolic disorder of mineral imbalance, just not the weak bones. So we monitor PTH, calcium, phosphorus, vitamin D, and try to keep them to normal level. So thank you for watching and have a great weekend.